Hello everyone, hope you're all doing good. This is Dr. Agalya Kulandevelu, your organic faculty. So in this video, we are going to continue with our discussion on image-based series. We are going to do our obstetrics part 2 here, right? Now, if you see this image, you'll be able to understand what we are going to discuss. Yes, we are going to discuss about multiple pregnancies, okay? So, if the cleavage is happening in the days 1 to 3, at the morula stage, then you will be getting dichorionic, diamniotic twins. If the cleavage is happening at the blastocyst stage, that is on days 4 to 8, you will be getting monochorionic diamniotic twins. And if the cleavage is happening in an implanted blastocyst between days 8 to 13, you will be getting monochorionic, monoamniotic twins. And finally, when the cleavage is happening between days 13 to 15, you will be getting conjoined twins. Okay. This is important. So, let us see what is this monochorionic, monoamniotic twins. Monochorionic, monoamniotic twins means they share one placenta. Okay, they share one placenta and they have only one sac. That is one amniotic sac and one chorionic sac. But there can be any number of fetuses, but in twin pregnancies there will be two fetuses and they will have two separate umbilical cords. Right? When we talk about monochorionic diamniotic twins, they have one chorionic sac and two amniotic sacs. Okay, two amniotic sacs. That's why it is diamniotic, right? They have one placenta, two fetuses, and two umbilical cords, right? And in dichorionic diamniotic twins, you will have two chorionic sac, two amniotic sac, two placenta, two fetuses, and two umbilical cords. Okay, just like two normal different pregnancies. Everything will be two. So one common thing what we have seen here is whatever may be the amnion, chorion or anything, okay, you have to know if two fetuses are present, two umbilical cords are present. So, 3 fetuses are present, 3 umbilical cord will be present. Okay, so n number of fetus present, n number umbilical cord will be present. That should be made clear, right? Yes. Now, let us see some of the important features about dichorionic and monochorionic twins. Then, I will tell you the importance of this umbilical cords, right? Yes. So, dichorionic twins and monochorionic, we see the number of layers. In dichorionic twins, there will be 4 layers of the membranes, right? And in monochorionic twins, there will be only 2 layers of membranes. Similar way, the thickness of the layers that is present between them is going to be more in dichorionic twins, that is, it is going to be more than 2 mm, whereas in monochorionic twins it is going to be less than 2 mm. And if you see the specific sign of dichorionicity, you will be able to see twin peak sign, or it is also called as lambda sign. Whereas in monochorionic twins, this is going to be a T sign. Is that clear? So, this differentiating feature is very important to identify between your dichorionic twins and monochorionic twins. Okay. Now, let us try to identify the different types of placenta present here, right? So, in the first picture, you are able to see that you have two umbilical cords and you have a thick membrane in between. So, this is going to be, and this appears to be a single placenta only, right? So, it is going to be monochorionic diamniotic placenta, right? And here, if you see, yes, there are two umbilical cords which are intertwined with each other. Yes, but you are able to see two umbilical cords and there is no such separation seen here. So, this is going to be a monochorionic, monoamniotic twin placenta. Is that clear? Right. Now, let us see these two signs in ultrasonogram. Okay. So, first one is a lambda sign and the next one is a T sign. Okay. So, what is lambda sign? So, if you ask what is lambda sign, see what is actually happening is you have a triangular appearance here, right? So, this is nothing but the chorion that is insinuating between the layers of the intertwin membrane, okay? And if you see this lambda sign, then it suggests it is dichorionic diamniotic twin pregnancy, okay? And this is most commonly seen in the first trimester, especially between 11 to 14 weeks, 10 to 14 weeks, and the presence of this strongly suggests that it is going to be dichorionic diamniotic twins, but however, if you are not seeing this sign, then you cannot exclude dichorionic diamniotic twins. Is that clear? Right. And the next one is T sign. Okay. So here, if you see the T sign, you are not able to visualize anything properly, but you are able to see one small membrane that is going here, and when you join it with this, you are getting a T shape, right? So this is T sign, and T sign is seen in monochorionic twin pregnancy. Okay, it is seen in monochorionic twin pregnancy. That means it is just only the membranes. Okay, no placenta is coming inside the membranes, right? So this is lambda sign and this is your T sign, right? Now let us see this one. So these are the various types of conjoined twins we have. Okay, so you have thoracophagous, that is joined at the thorax, then omphalophagus joined at the umbilicus, then cephalophagus at the head, tissue-phagus at the ischial tuberosity, pyophagus at the back, and the craniophagus at the head. Okay, you have paraphagus disulfus, paraphagus diapropus. That means it is joined in the upper trunk completely, and here head and upper trunk completely. Then rachiphagus, which is joined at the back. Okay, so these are the different types of conjoined twins you have, and among these, thoracophagous is said to be the commonest type of conjoined twins, and thoracophagous and omphalophagus together itself will make about 75% of the cases. Okay, so the two babies face each other face to face, and they share a common sternum and diaphragm as well as abdominal wall. Okay, so this is how it will be, right? So these are the types of conjoined twins. Now see this picture. What you are able to see? You are able to see twin pregnancy, but one baby is comparingly short and it seems the growth is not well adequate, whereas one baby seems a big baby and it is erythematous also, right? And this baby seems somewhat pale, right? So what it is? Yes, it is going to be a twin to twin transfusion syndrome. What is this? It is twin to twin transfusion syndrome, right? So now let us discuss about twin to twin transfusion syndrome. Why does this syndrome occur? This occurs because of deep arteriovenous anastomosis in your monochorionic twins. Okay, and what is happening here is blood from one fetus will be constantly going to the another fetus. So if you see, this fetus is going to be a donor fetus and this fetus is going to be a recipient fetus. Okay, so the donor fetus is going to be having anemia, FGR, and the liquor in which this fetus is present is also going to be less. So this side it is going to be oligohydramnios. Okay, whereas on the opposite side it is going to be anemia, means this side it will be polycythemia because there is circulatory overload here, right? And FGR means here the baby is going to have a circulatory overload and so it appears big, right? So it appears big baby, there is circulatory overload. Then finally you have polyhydramnios. Okay, now when this is proceeding in very serious way, what happens means the donor twin finally becomes very much smaller and it becomes something called as stuck twin. Okay, and if one fetus is dying, then what happens? The surviving fetus will suffer from neurological complications. Okay, neurological complications as well as multi-organ failure, because there will be neurological hypotension, right? There will be neurological hypotension, right? So this one you have to know. So for this we have a staging for TTTS, that is twin to twin transfusion syndrome. We have a staging. That staging is called as Quintero staging. Okay, it is called as what? Quintero staging. So let us discuss only the specific features of this Quintero staging, right? So, in stage 1, one twin will have polyhydramnios and the other twin will have oligohydramnios. Okay. So, that means if you take STP, single vertical pocket, then it is going to be more than 8 centimeter, and here it will be less than 8 centimeter, less than 2 centimeter, right? So, this one we have to know. And the next one is second stage, where the donor bladder is not visible, okay? And third stage, you will be able to see abnormal Doppler. Fourth stage is where you will be seeing hydrops in either twins, and fifth stage there will be demise of either. Clear? So, this is all about quintero staging. Now, if we talk about the management of twin-to-twin transfusion syndrome, if left untreated, then the mortality rate is going to be about 80 to 100%. Okay. Suppose if it is in quintero staging 1, then you can plan expectant management. Okay. So, from stages 2 to 4, when the gestational age is less than 28 weeks, you can offer them laser ablation of the communicating vessels. Okay. And if they present between some 34 to 36 weeks, okay, you can offer them a course of steroids and then deliver them, right? So, that is how you manage the TTTS, right? Now, let us in detail see how we will manage the twin pregnancy as such, right? Now, let us see how we will manage twin pregnancy as such, okay? So, first let us speak about the presentation of the first twin, okay? So, the first twin can have a vertex presentation or non-vertex presentation, okay? So, if it is going to have a non-vertex presentation, then straight away you will take the patient for a cesarean section, right? Suppose if the patient has vertex presentation of the first twin, then you can try to offer her a natural labor, okay? So, then it depends upon the presentation of the second twin. The second twin can be either vertex or it can be breech, okay? Suppose first twin is vertex, second twin is also vertex, then no problem, okay? So, first one will deliver by natural mechanism of labor, and second one also will follow the same mechanism. There is no problem at all, okay? So, you can offer them both vaginal delivery, right? Suppose first one is vertex and second one is breech. You can offer normal vaginal delivery for first twin, and the second twin you can give assisted breech delivery, okay? Or even you can give them assisted breech extraction. Extraction means completely you will extract the baby. Assisted breech delivery means you will be allowing the baby itself to follow certain mechanisms, and you will be only assisting at certain steps, right? So, either assisted breech delivery or breech extraction you can do, right? Yes. Then, suppose if the second twin has one more problem, okay? Suppose the second twin has transverse lie, then what you will do? You will give the first twin vaginal delivery, and for the second twin you will attempt external cephalic version, right? And with external cephalic version, either you can, external cephalic version means moving the baby through the abdomen, okay? Either you can bring the baby to a vertex presentation, or you can bring the baby to a podalic presentation, right? So, if you bring the baby successfully to a vertex presentation, then yeah, you will offer her a vaginal delivery. Suppose if you are bringing the baby to a breech presentation, then you will give the baby either assisted breech delivery or breech extraction, right? And suppose if there is a failure of ECV, okay, suppose ECV has failed, then what you will attempt? You can attempt something called as IPV. What is this IPV? IPV is nothing but internal podalic version. See, this is the only indication of doing internal podalic version in obstetrics, where the delivery of the second twin is not possible when it is in a transverse line. Okay, so external cephalic version means what we did, we moved the baby through the abdomen, whereas an internal podalic version will be leaving our hand into the uterus itself and will be trying to catch hold of either the vertex or the podalic part of the fetus and try to bring it down. Mostly we will be trying to catch up the podalic part. Okay, so you just have to check whether the membranes are intact here or not. Suppose if the membranes are intact, offer her an ARM and try IPV and hold the podalic version. Okay, and hold the podalic region and go for breech extraction. Okay, and go for breech extraction. Okay, suppose if the membrane is drained out, okay, will you be able to perform this internal podalic version? No, it is not possible, right? Because there will be difficulty in holding the baby and bring it down. Okay, so at that time, suppose the liquor is not adequate, then you will offer her cesarean section directly. Clear? So, this is all about the delivery of multiple pregnancy. Okay. Now, one more point I want you to add, at what gestational age you have to plan delivery for this twin babies. Okay, suppose if the baby is a DCDA baby, okay, then ideally the delivery can be planned normally around 38 weeks of gestational age. Suppose if the baby is MCDA, then you have to plan it around 34 weeks to 37 weeks plus 60s. And finally, if the baby is MCMA, then you can offer delivery between 32 and 34 weeks. Is that clear? Right. Now, see this. So, what does this indicate? The baby is having a podalic presentation. So, that means we are going to talk about the breech, right? Okay. So, here we have three types of breech. First one is a frank breech, next one is a complete breech, and next one is a footling breech. Okay. So, in complete breech, what is happening? You are able to see the extremities are in a flexed attitude, right? So, the extremities are having a flexed attitude, and what you will be able to feel while you do a PV when the baby is in this presentation. You will be able to feel the buttocks, okay, either side of the buttocks you will be able to feel, then feet also, then also the external genitalia. Can you imagine? So, all these things will be palpable while you do a PV in this baby, right? So, this is a complete breech. And in frank breech, what is happening is there is extended legs, okay, you are able to see this, there is extended legs in this baby, okay, and the thighs are flexed, okay, extended babies and the thighs are flexed, right? So, this is a frank breech, okay, and this is footling breech where you will have flexion of hips and flexion of knee as well, okay. So, that is footling breech. While you do a PV, you will be able to hold the foot of the baby, right. So, this is a breech presentation, okay. Now, if you see in these three types of breech, the frank breech prognosis is going to be best, okay, because the presentation itself is going to act as a cervical dilator here, okay, and the chance of cord prolapse is also going to be less, and this is most commonly seen in primigravida, right. And when you talk about the complete breech, you are able to see the prognosis somewhat good, but not as good as the frank breech, okay. However, the prognosis is also good here, and it is most commonly seen in your multigravida, okay. and the worst prognosis is seen with your footling breech. Okay, the worst prognosis is seen with your footling breech, right? Okay. Apart from these three types of breech, we also have something called as star gaze fetus. Okay, or otherwise we can also tell it as flying fetus. Okay, so this is a fetus where the head is going to be in a maximum hyper extension. Okay, so if the baby is having this stargazing attitude, then definitely vaginal delivery is going to be difficult and it may result in injury to the spinal cord. Okay, so if you find this attitude, definitely you have to offer the patient cesarean section. Is that clear? Right. Now see this. So what is being tried here? So the baby is in breech position and they are attempting to change the attitude of the baby by moving it, and finally they have brought it to a vertex presentation. So what do you think? This is going to be your external cephalic version, right? So this is going to be your external cephalic version, right? So when you will do external cephalic version can be attempted in any breech by 36 to 37 weeks, okay, and you have certain prerequisites for performing this external cephalic version. The prerequisites are: first, you have to get a consent from the mother, then you have to check the volume, okay, so the Liker volume that should be adequate. You should know the placental position, it should not be a placenta previa or any other abnormality in placenta, okay, so placenta should be normal. The fetus should have adequate growth and it should not have either FGR or macrosomia, and an NST taken before should be normal, and this should be performed under ultrasound guidance, and it should be happening in a tertiary care center or any place where you can take the patient through a cesarean section if something adversely is happening, right? Yes. So these are the prerequisites. And what are the contraindications of external cephalic version when you shouldn't attempt this external cephalic version at all? Okay. So contraindications: when you have multiple pregnancy, you shouldn't try, or there is antepartum hemorrhage or placenta previa, just like how we discussed here, already ruptured membranes, that is also another problem when the fetus has significant abnormalities. Okay, we are not going to attempt it. Okay, so relative contraindications can also include previous cesarean section in the mother, or there is severe PAH. Okay, and remember, external cephalic version is also an indication for giving your anti-T. Okay, so when you perform this procedure, even if it is successful, you have to give anti-T if the mother is going to be RH negative. Clear? Now, let us talk about this one. So, what is this one? So, this is what I spoke about. Okay. So, that is external cephalic version. Here, the hand is inside the uterus, and again they are attempting to turn the baby's position. So, this is going to be your internal podalic version. Okay, this is going to be your internal podalic version. Okay, so this is usually done in the second stage of labor when you want to change the. So, this is usually done during your second stage of labor when you want to change the presentation of the fetus. Okay, especially in a second twin, when it is in a transverse lie or an oblique lie, mostly you will be bringing the baby to a podalic presentation and you will be doing breech extraction. Is that clear? Right. So what does this picture? So this picture is showing they are attempting to extract the baby by holding its groins, right? So this is a groin extraction. Okay. So this is mostly done in a breech with extended legs, but has an arrest at the outlet. Clear? Right. Next, so this picture. So what they are doing here in this picture? First, they are letting the baby to hang down. Okay, no one is holding the baby is hanging down on its own. Then they are trying to grasp the baby by holding the feet, and finally they are swinging the baby over the maternal abdomen, right? So they are trying to swing the baby over maternal abdomen. So what do you think this technique is? Yes, this is going to be a Burns-Marshall technique. Yes, very good. This is going to be a Burns-Marshall technique. So this is one of the technique of delivering after coming head in a breech presentation. We have three methods. So this is your first method of delivering after coming head, and this is your second method. Okay. So what they are doing in this method, if you see, number one, you have three hands. That means there is an assistant also. Okay. So there is an assistant here who is giving pressure, and if you see this operator's hand, the middle finger of this hand is going to be on the occiput. Okay, middle finger on occiput, and here the other hand's fingers, you will be having two fingers over the malar eminences. Okay, two fingers on malar eminences. Okay, this will be mostly your index finger and your middle finger, right? So you will be holding the baby like this. Okay, so two fingers will be like down, like this. You will be holding the malar eminences, and the other finger will be like this. You will be pressing the occiput of the baby and maintaining the flexed attitude of the head by giving pressure using your middle finger right here. Okay, then you will be holding and just extracting the baby out, right? So this is nothing but your, yes, this is nothing but your Mauricio Smiley-Wyatt maneuver. Okay, Mauricio Smiley-Wyatt maneuver. Okay, your second technique of delivering your after coming head, right? Now, this is another method of delivering your after coming head, and the final method where you will be using a forceps. Okay, what is this forceps called as? Yes, it is going to be known as Piper's forceps, right? So this is a Piper's forceps, a specially designed forceps to deliver your after coming head alone. Okay. So what is the speciality in this forceps means? You have a reversed pelvic curve. Okay, you have a reversed pelvic curve. Okay, when we talk about instruments, you know about it clearly. For now, you remember Piper's forceps is something which will be having only one curve right here to hold the head of the baby alone. Here you don't have any curves at all, or it will be a reversed pelvic curve and it will be somewhat straight looking. Okay, and Piper's forceps is another method of delivering your after coming head. So three methods of delivering your after coming head are: one is Burns-Marshall technique, second one is Mauricio Smiley-Wyatt method, and the third one is your Piper's forceps. Is that clear? Right. Now what is this maneuver? This maneuver is Pinard's maneuver. Okay, so this maneuver is a Pinard's maneuver. Okay, so here the breech with extended legs will be getting arrested at the pelvic cavity or above. Okay, so groin traction is usually given when the breech is getting arrested at the level of perineum. Okay, suppose here the breech is getting arrested above the pelvic cavity. What you will do? See, what they are doing means here, okay, the index and the middle fingers are taken inside and they will be giving a pressure on the popliteal fossa of the extended leg. Okay, when you give the pressure, there will be spontaneous flexion of the legs and it will be falling down. And soon after the legs are falling down, the legs will be abducted and it will be grasped down and it will be brought out. Okay, so the similar way you have to bring the other leg also, and finally you have to do a extraction, right? So this is Pinard's maneuver. Okay, so this is a breech delivery where you will be converting a frank breech into fruitling breech. Okay, so this is a frank breech. You will convert them into fruitling breech and you will do a extraction, right? So this procedure, that's why we have to do this procedure under anesthesia. Okay, we have to do it under anesthesia, right? Now, see this maneuver. So, what they are doing here, the fetus is being held by the hip, right? So, the fetus is held at hips and finally they are attempting, see this side, only the back of the fetus you are able to see. So, this side we are able to see the front side of the fetus. So, that means it is rotated. Okay, so it is rotated through 180 degrees. Okay, and finally what is happening? The fetus is again rotated back, okay, in the opposite direction. Okay, it is rotated in opposite direction so that the shoulder and arm are delivered. So here also one shoulder and arm have come outside and here also another shoulder and arm have come outside. So what is this maneuver? This maneuver is a love sit maneuver. Yes. Okay, so this is a love sit maneuver. Okay, so this is used when the baby has displacement, upward displacement of arms. Okay, so first we will be rotating the baby around 180 degrees and we will be delivering the posterior shoulder and arms, and again it will be rotated in the opposite direction and we will be delivering the anterior shoulder and arms. Okay, so this is love sits maneuver. Now let us see what this maneuver is. What is this? This is a frog maneuver, right? So this is a frog maneuver. So here the baby is in occipito-posterior position, right? So the baby is in occipito-posterior position, and what you are doing is you are delivering the head by reverse jaw flexion and shoulder traction. Okay, so these two things are done here and the baby will be delivered as face to pubis. Okay, there will be face to pubis. Okay, so there is reversed jaw flexion and shoulder traction, right? So this is frog maneuver. And this method where you will be delivering the head by giving the incision on the cervix. You will be cutting through the cervix. So these incisions are called as Sen incisions. Okay, so this will be usually given at 10 o'clock, 2 o'clock and 6 o'clock position. Okay, so that is Darson's incisions. Now, this baby is found to have a swelling at the face, over the abdomen, so the asset is present, and overall the baby seems to have fluid overload, right? So this baby is going to have this baby is a hydrops baby, that is, hydrops is nothing but water, so water retention everywhere, right? So this is hydrops fetalis. Okay, so there are so many causes of hydrops fetalis, and the most commonly asked question is, what is the immune cause of hydrops fetalis? Yes, immune cause of hydrops fetalis is your Rh negative incompatibility, right? You also have so many non-immune causes of hydrops fetalis also. Non-immune causes will include infections like parvovirus, B19, or it can be alpha thalassemia, any cardiovascular defects or chromosomal abnormalities. Okay, abnormalities. Then it can be also due to your fetal anemia. Okay, and so many reasons, but the most important question they ask us, what is the immune cause of hydrops fetalis, which is going to be Rh negative incompatibility. Okay, right. Now let us discuss about the management of Rh negative incompatibility, because I know knowing about what is Rh negative incompatibility, the different blood groups, the pathogenesis, which baby will be affected, how it will be affected, will be easy for you. One day confusion will be there with the management. We are going to discuss about the management on Rh negative incompatibility, right? Yes. So, whenever you have Rh negative mother, you have to check the blood group of the father first, okay. So, when you check the blood group of the father, and if he also has an Rh negative blood group, then you will offer them routine care, okay. Then there is another option, like the patient, that is the father can become, repeating once again, there is another option, that is the father can be Rh positive, okay. So, if this is there, then at the booking visit itself, what you will do? At the booking visit itself, you will offer them ICT, that is indirect Coombs test, and you know ICT can be either positive or negative, right? Now, let us discuss what will you do in a ICT negative female, okay. So, in a ICT negative female, you will repeat ICT again, okay. So, repeat ICT again at 28 and 36 weeks, okay, and you have to offer her anti-D between 28 to 32 weeks. You will plan delivery around 40 weeks, and post delivery also you have to give anti-D prophylaxis for the next pregnancy within the next 72 hours, okay. So, this is post delivery, right. So, this all concepts are for a primigravida. Suppose she is a multigravida, okay. What you will do? For a multigravida, that is who got her ICT negative at the booking visit itself, you will repeat it again at 4 weeks, then 4 weekly you have to repeat, okay. That should be started from 24 weeks, okay. From 24 weeks, every 4 weeks you have to repeat the ICT and C, right? Yes. Now, let us discuss what if the other way around, okay. Suppose if there is ICT positive at the booking visit itself, okay, then you have to look for the parent's genotype, okay. Find out the parent's genotype. It can be homozygous or heterozygous, right? So, it can be homozygous or heterozygous. So, if it is going to be heterozygous, then you will check for the fetal blood group, and it can be done by amniocentesis or cell-free fetal DNA that is obtained from the mother's blood, okay. And here you have two options. The fetus can be either Rh negative or Rh positive, okay. If the baby also becomes Rh negative, means then you will follow your routine, okay, how you will deliver, right. Suppose if the parent's genotype is going to be homozygous, then definitely the chance of baby being Rh positive is going to be high, okay. So, what you will do in that case? Suppose if it is going to be first pregnancy, then antibody titer should be done every month up to 24 weeks, then it will be done every 2 weeks, okay. Suppose if the titer is less than 1:16 or less than 15 international units per milliliter, then you can safely plan delivery at 38 weeks of gestational age. Okay. Suppose the patient is a multigravida and she has a previously affected pregnancy, then you have to check and when you check the titer, it is also going to be more than 1:16 or more than 15 international units per ml, and other criteria I said is she has a previous affected pregnancy. So, if this is happening, then you will offer her serial middle cerebral artery fetal Doppler. Okay. So, in the serial MCA fetal Doppler, you will check your middle cerebral artery peak systolic velocity. Okay. The cutoff is more than 1.5 MOM, that is multiples of median. Okay. So, if it is not coming to that level, then you will do routine antenatal fetal monitoring and then repeat middle cerebral artery peak systolic velocity Doppler weekly. Okay. Then whenever it becomes less than 1.5 multiples of median, you have to deliver her. Suppose if it is maintaining above 1.5 multiples of median, then you can deliver her at 38 weeks. Clear? And the next point is, suppose the peak velocity in the middle cerebral artery is going above 1.5 multiples of median and the gestational age is also important, right? Suppose the gestational age is going to be less than 35 weeks only. Then in this case, you will offer her chordocentesis and you will check the fetal hematocrit. If the fetal hematocrit is becoming less than or equal to 30%, then you will offer intrauterine transfusion to the baby around 34 to 36 weeks, you will deliver the baby, right? Suppose if it is more than 30%, then you will deliver it directly around 34 to 36 weeks. Is that clear? Right. And suppose if the peak velocity is more than 1.5 multiples of median and it is more than 35 weeks, what you will do? Every 2 to 3 days you have to repeat the Doppler. Okay, you have to see the middle cerebral artery peak systolic velocity, and whenever it is increasing, okay, you will offer her steroid coverage and you will deliver her immediately. Clear? So, this is how Rh negative pregnancy is managed, right? Now, see this picture. What you are able to see? You are able to see a fetal skull with overlapping bones, right? And here in the heart, you are able to see some echogenic material, right? So, this is suggestive of, yes, intrauterine death. Intrauterine death. So, this sign where there is overlapping of fetal skull bones is seen. Okay, you are able to see overlapping of fetal skull bones. This sign is called as Spalding sign. Okay, the sign is called as Spalding sign. Whereas here, where you are able to see a gas shadow, right? So, this is a gas shadow in the heart. So, this sign is called as Robert sign. Okay, so these are the signs of intrauterine death. We can have some other signs also. Number 1, there can be absent heartbeat. Number 2, there can be absent fetal movements. And gross fetal anatomy can show maceration after delivery, and the skin tissue edema will be there, that is skin thickness will be more than 5 mm, and there will be echogenic amniotic fluid. Okay. So, these are the other signs in intrauterine death, right? Yes. Now, what is this? You are able to see the mother is lying in the supine position and the fetus along with the uterus, okay, which is having more weight now, is going to compress on this vessel. Okay, this vessel is nothing but your inferior vena cava. So this is your inferior vena cava and the patient is lying supine. So when this is happening, you will get a syndrome called as supine hypotension syndrome. Okay, so this happens especially in the third trimester when the baby is fully grown. Okay, so in the third trimester, when the baby is fully grown, if the patient lies supine, what is going to happen? The gravid uterus is going to compress on the inferior vena cava, and when this is happening, there will be reduced venous return and there will also be reduced cardiac output as well, and that will cause two things. One, there will be hypotension in the mother and there will also be reduced fetal blood flow, right? So that will lead to fetal distress in the baby as well. Okay, so this is supine hypotension syndrome, right? Yes. Now, okay, now let us discuss about the stages of labor. So first stage is when the cervix relaxes, causing it to dilate, thin out. Okay, then in stage 2, you will be having uterine contractions that will be increasing in strength and the infant is delivered. And stage 3 is where the placenta is expelled. Okay, we have 3 stages of labor, right? Now, let us discuss about how many hours these stages will be lasting in both a primary as well as in a multi. Okay, so we have the primary gravida here, multi gravida here, and so first stage is divided again into latent and active phase. Okay, so in the first stage we have latent phase and active phase, and we have the second stage here and third stage here, right? Yes. Now, in the primary gravida, the latent phase lasts for approximately 20 hours and in the multigravida, it is going to be 14 hours. Okay. So, first stages from the onset of uterine contraction till the dilatation, complete dilatation of the cervix. Complete dilatation of the cervix means up to 10 centimeter dilatation of the cervix. Okay. So, in the active phase, it should proceed at a speed of 1.2 centimeter dilatation per hour in a primary gravida, whereas in a multigravida, it is 1.5 centimeter per hour. Okay, if you take approximately, it is 1 centimeter per hour dilatation should be there in both primary as well as multi, right? And in second stage, so maximum hours it can go was up to 3 hours in a primary gravida, whereas 2 hours in a multigravida. Okay, suppose when the patient is given epidural for pain relief, then it will take additional 1 hour plus 1 hour in both the patient. That means in primary gravida it will be 4 hours and in multigravida it will be 3 hours, right? And third stage will take approximately 20 minutes. Okay, that is the expulsion of placenta will take in another 20 minutes. So till 20 minutes you can wait for placental delivery, right? Yes. Now apart from these 3 stages, we have another stage. Okay, we have a fourth stage as well. So this stage is nothing but your postpartum period. Okay, so this is nothing but your postpartum period. Okay, so in that we have an initial or acute period, that is in the first 6 to 12 hours postpartum. Okay, so here you will be having rapid changes, okay, in the female, like there will be rapid changes with the potential for immediate rises. What are the immediate rises? You can have PPH, or there can be amniotic fluid embolism. Okay, amniotic fluid embolism. Then uterine inversion, even eclampsia can happen. Okay, so these are the risks in the immediate postpartum period. And in the second phase, which is seen between day 2 to 6 weeks approximately, the body will be going for many major changes here. Okay, in terms of, repeating once again, And the second phase is subacute postpartum period. Okay, it is subacute postpartum period. So this is seen between 2 to 6 weeks. Okay, here all the changes that has taken place in the pregnancy is going to get back to its normal levels. Okay, that will include your changes in the hemodynamics or genitourinary system, metabolism, and even emotional changes. Okay, but these changes are less rapid when compared to the changes that has happened to the acute phase. Okay, these are less rapid and the patient itself will be able to self-identify any problems that is occurring in this phase. Okay, and the final phase is delayed postpartum period. This can last up to 6 months. Up to 6 months. The changes that is happening in this phase is very gradual and problems are also relatively rare. Okay, so this one you have to know. Now,